and my dear students and dear colleagues, I welcome you all once again for this Railway DNB Anesthesia online activity. Today we have Osce pattern discussion. Over to Professor Nagaswamy, sir.
Okay. I hope you all of you got a link sent by topics where we will be discussing. Straight away go to PP for the question. Visible?
Sir, visible, sir.
PPT is not visible?
PPT is visible, sir.
So as I told last time, you usually get 2 long cases and 4 short cases, along with 23 other items like instruments, maybe report or XCG, X-ray, some quality and qualifications. Based on that, we have now got first 2 long case scenarios. Just see the scenario, and one of you can say how we will be answering this question within that short 15 minutes time given to you. How will you discuss this question? So the first case scenario is about this patient looking normal or slightly obese. You can unmute and answer. Whoever wants to answer. The voice okay now?
Yes, sir.
So my Vasanthi said the voice is breaking. I don't know whether the microphone is. So there is a 32-year-old lady weighing about 120 kgs, height of 175 centimeter, posted for liposuction and abdominoplasty. She gives history of heavy snoring at night with disturbed sleep, also complaints of daytime somnolence and headache. Recently diagnosed to have diabetes mellitus and started on oral hypoglycemic agents. So how to discuss this case? She is a 32-year-old lady, weight 120, height 175. So you have to calculate the BMI. Can you quickly calculate and tell me what will be the BMI? Calculate the BMI. The participants are questioned to talk by unmuting. You can quickly calculate using your calculator in the cell phones. The formula to calculate BMI. Actually, I think they are all muted or not participate. Now, hello.
Is search for voice audible continuously or voice is breaking? Participants?
My voice is okay? My audio is okay?
Yes, sir. I am able to hear, sir.
And nobody is answering. How to go for this? It's a problem here. What shall we do? They are not able to participate. Come actually. I go ahead and complete it on my own?
I think they're not able to follow your question, sir. It is breaking, sir, in places.
Okay, but it is visible on the screen.
Yes, sir. Yes, sir. Obviously, the first question will be what is BMI. So they simply have to answer. Yeah, that's right.
Anybody from the participants? Sir has asked, what is BMI?
How do you calculate BMI? That's the first thing, isn't it? As soon as you see any obese patient, first thing they will ask you is how do you calculate BMI based on the height and the weight of the patient.
That's the reason purposely I have not straight away given the BMI, just to find out whether they are aware of the formula or not. Even though it may be a little difficult mathematics, at least with the cell phone.
Weight in kg divided by height in meter square, sir. Cutilate index.
Yeah. So whether you use your cell phone and quickly calculate, then tell me the BMI.
Yes.
Weight in kg is 120. Height is
Yes, sir.
already given 172 centimeters, which you have to convert it into meter, 1.72 meters it will be. So square that and use it as a denominator.
BMI 41.5, sir.
1.5. Okay. So you see, under what category does it come?
Morbid obese.
Morbid obesity. Okay. So here is a lady, morbid obesity, posted for liposuction and abdominoplasty. What type of surgery it is? Is it a life-threatening surgery or a cosmetic surgery?
Cosmetic ones.
It's a cosmetic surgery, so there's no urgency about it. Okay, so she
Yes, sir.
feels she is very obese and she wants to get rid of the excess fat, so she has gone probably to a plastic surgeon who wants to do and get a tummy tucking. The other name for this abdominoplasty is tummy tucking. Make the tummy look big and slim. Okay, so that is the surgery she wants to undergo. But she has got some other additional comorbidity, which is not, the name is not given, the diagnosis is not given, but the symptoms of that particular comorbidities are given. What is the comorbidity that is present in her? He has got disturbed sleep, he has got daytime somnolence, headache. Which comorbidity in obese patients this sort of problem will happen? The person who answered the first question, can you continue? Please say we cannot diagnose or find out, so that I can proceed. I'm not seeing any faces here.
Voice is, sir, sorry, sir. Voice is breaking, sir.
Whose voice is breaking?
Unable to. Yes, sir.
My voice? Mine?
Yes, sir. Yes, sir. It's not clear, sir.
No, even if the voice is breaking, whoever is answering, even if the voice is breaking, you must understand the question because it's very, very simple, basic question that sir is asking, right? First, he asked you, what is BMI? How do you calculate BMI? And then he's given you some symptoms. That patient has has snoring, has daytime somnolence, has disturbed sleep. So what does that patient have? That's all he wants to know.
Obstructive sleep apnea syndrome.
Obstructive sleep apnea. So OSA. My voice now better?
Yes, sir.
Okay, probably my microphone was not
Sir.
proper position. Okay.
Sir, it's still breaking only, sir.
Okay.
Yeah, ma'am.
I'll just try to change my headphones and see.
Okay.
Is it better now?
Yes, sir. Yes, sir.
Yeah, old is gold. So my grandson got me a new headphone through Amazon. I don't know why it is giving problem. It's a new one.
This is good, sir.
Anyway, okay. So the comorbidity she has now is OSA. Any other comorbidities? As per the case scenario given? Is it audible now?
Very much audible, sir. But the
Please.
screen is blank, sir. Can we flash the slide again?
No, okay, I'll go back to that.
Diabetes mellitus, sir.
Yeah, she has, it's only a 4-line case scenario. So the moment you see that, you should pick up all these points. That is the because you have very limited time in the examination. So you should develop the quick grasping and observation skills. Okay. So 32 years old. She's not very old. Okay. A fairly young lady. But the BMI calculated as per the person who did the mathematics, 42.1, which is on the morbid, supermorbid obesity. And heavy snoring at night with disturbed sleep and daytime somnolence, indicative of obstructive sleep apnea. Along with that, she has been recently diagnosed to have DM, started on oral hypoglycemic agents. So how to go about and give anesthesia for this lady is the case scenario. Okay. So how will you approach this problem? What are the challenges now you face? Here is age-wise, she is not a very old person, but BMI-wise, she is in the morbid obese side. And she has got OSA, she has got DM. 3 problems are there. But the surgery posted is very superficial, innocuous surgery, cosmetic surgery, nothing intra-abdominal or major vascular or anything like that. So how do you anesthetize or how do you proceed to evaluate this lady? What will be the challenges you will be facing due to the obesity per se, secondly due to the OSA, and thirdly due to the DM? How do you go about?
There will be anticipated difficulty airways.
Very good, excellent. Okay, so first of all, due to obesity, what are the other problems you can anticipate? Airway is the main problem, but apart from the airway, what other problems you will have because of obesity?
We should look out for cardiovascular systems.
Every system you have to examine: cardiovascular, respiratory, metabolic, musculoskeletal,
Yes.
venous axis.
Yes,
Then accommodating the patient on the operating table, how much, whether the normal operating table can hold her. Even though I could not get a really morbid obese patient, I just got a patient who looks almost like a modern lady only. She doesn't, the picture doesn't say that she is morbidly obese. She is on the obese side, but doesn't look like to be a morbid obesity with flowing fat all over the body. Okay. So that is the challenge. What about individually there will be some changes in every system in the body due to obesity. Okay. And what about this OSA? What problems can it give you? What are all the things that you have to know about OSA? Do these patients, can they tolerate opioids like normal patients?
no, sir.
So they will be very sensitive to opioid. They can go for easily airway obstruction or respiratory depression. And chronic OSA, if not have been diagnosed and treated, what are the changes that could have produced in the body? Which systems could have got affected?
Sir, in respiratory system, there will be reduction in FRC and there will be decrease in lung compliance.
Long-standing untreated OSA, what can it produce? Patient is having desaturation in the night several times, wakes up, hypoxemia, chronic hypoxemia, What are all the changes it can produce?
Obesity, hypoventilation syndrome.
Okay, so ultimately,
Then
what
that will
it will
lead to
lead it
something
to?
else.
Cardiovascular. What will be the pulmonary pressures like? Will they develop pulmonary hypertension over a period of time?
Yes, sir.
Will this pulmonary hypertension, will it affect the right heart?
Yes, sir.
Yes, sir.
Right heart failure will have.
Right heart failure shaken. Okay. So due to obesity, they could have developed hypertension, systemic hypertension, which could lead to left heart problem. Due to OSA, they could have developed pulmonary hypertension and right heart failure. So ultimately, if both the ventricles fail, what do you call that condition? Left ventricle also is not functioning well. Right ventricle also is not functioning well. Then what do you call that? Biventricular failure. Since both the ventricles are failing. So they may ultimately land up with biventricular failure. Okay. And diagnosis of DM. What do you want to know about it? Recently diagnosed, but we do not know the duration. Maybe say 2 months or 3 months before she was diagnosed with DM. So what relevant history you want to know about the DM status?
So there can be
Whether
autonomic
sugars are
dysfunction.
Whether the sugars are under control, how it was detected, what was the original value when it was detected, whether already has she target, because many a times diabetes exists without any symptoms for a long time. And by the time you detect, already some damage has occurred in various organs. Okay, so target organ dysfunctions, whether it has taken place. Okay, so that is another point that you have to make sure. So with all these things, now, how do you optimize this patient? This is not, as I told, it's a life-threatening emergency. It's only a cosmetic procedure. So can you take a little time to optimize this patient to manage all these complications that is already present in the patient? How do you optimize?
weight reduction.
Weight reduction, very good. How do you do weight reduction? What are the methods of doing weight reduction?
So advise them for physical activities.
Increase physical activity, dietary adjustments, ask them not to eat
Lifestyle
junk.
changes. This is the word that we already
modifications.
discussed. Yes.
Very good.
Lifestyle
Lifestyle
modifications.
changes. Okay. Can any oral tablet or medical treatment help to get the weight reduced? Are there any medicines available for weight loss? Why they are not very popular?
Increase the side effects.
Most side effects. Very good. Okay. Right. So weight reduction is one option. But apart from that, what other things that you can do to optimize her? So you can advise her weight reduction by lifestyle modification. Then how will you control the OSA? Or how will you try to treat the OSA?
So CPAP or BiPAP.
Straight away you
Doing that,
focus.
before doing the CPAP BiPAP, would you like to do something else to see whether she requires the CPAP BiPAP?
Polysomnography, ma'am.
Yeah,
That's
you
right.
Apnea
assess the
hypopnea
severity.
index.
Index, very good. So you test, because she says she is having disturbed sleep and snoring and also daytime somnolence. You subject the patient to overnight polysomnography and assess the severity of OSA. Okay. And OSA can be treated in many ways. Lifestyle modification and weight reduction itself is part of the treatment in milder cases. But in more severe cases, you may require CPAP or BiPAP. Okay. So what is the
Surgical
difference between
treatment.
Surgical treatment is the ultimate last.
You will-
Even when
Yes,
you
sir.
say CPAP, BiPAP, if they don't work, then you have to think of surgical treatment. So what is the difference between a CPAP and a BiPAP?
So same pressure applied during both inspiration and expiration is continuous positive airway pressure, sir.
Very good.
In BiPAP, there will
Hmm.
be difference in pressure during inspiration and expiration, sir.
So which will be more, which will be less?
In inspiratory pressure will be more, sir,
More.
and expiratory pressure will be less, sir.
Less.
In
Okay.
inspiratory pressure, it will be 8 to 12, and in expiratory, it will be 4 to 5 millimeter of mercury, sir.
Centimeters of water. We don't talk about millimeters of mercury for airway pressures. Okay, it's always centimeters
Okay,
of
sir.
water. Right. So we can. So if you have to put this patient on CPAP or BiPAP, whatever you decide, what should you do about it? Any other instructions to be given to the patient once you start them on CPAP or BiPAP and they feel very comfortable after that, their sleep is quite sound, they never wake up in the night, their daytime somnolence is gone and headache is gone. Should you give any other instruction to them if they when they come to the hospital for surgery?
So ask them to bring the machine along.
So they should carry that machine to the hospital so that they can use their own machine. Okay, because they get used to that machine nicely, so they can use it instead of you trying to apply a new pressure and trying to manage them. Elective surgery, they can bring that machine to the hospital. Okay, right. Then what are the challenges on the table? How are you going to manage the anesthesia? What anesthesia you want to give for this particular surgery? Abdominoplasty and liposuction. Sometimes, even though they say it is abdominoplasty, they may go above the umbilicus up to the xiphisternum to suck out all the fat. So can this be managed under regional anesthesia or you want to give GA for this patient? What are the challenges you will face if you plan GA? What are the challenges you will face when you plan regional? This is how you analyze every case. Okay? Not only this case, any case scenario given, this is the pattern. You have to first get a thorough history. Then with the history, you evaluate the patient's condition, then assess the risk or the severity, then optimize as much as possible before surgery, then plan your anesthesia, whether GA or regional, then think about what are all the problems you have to face if you plan GA or regional, and adequately equip yourself to overcome those challenges. What are the post-operative plans or problems you can anticipate in a patient? Whether they will require any supportive ventilation, how are you going to manage the pain? What are you going to do about the fluids? How soon you can start the fluids? What are you going to do about restarting all the medications the patient has been taking preoperatively? These are all the general outlines through which you should discuss every case that is given to you in the exam or in your practice. Okay. So on the table, how are you going to manage? First of all, select your anesthesia.
I'll go for general anesthesia. For pain, I can go for regional. But only if we go for regional, then in case of emergency, if our block is not working, then it will be difficult to intubate the patient in case of an emergency. So it is better we prepare
Fantastic.
the
Very
patient.
good. Very good. That's a very good thinking. And secondly, you cannot decide the duration. Sometimes surgeons may take 4 hours, 5 hours also. So keep the patient under regional conscious in the same position also may be quite challenging. Okay. So you can think of GA if the procedure is going to be long, but you can use regional as a supportive or a multimodal method of managing the analgesia part of it. Okay. That's a good thinking. Very good. That is your plan. Okay. But how easy it is going to be to perform a regional in this obese patient?
So it will be very difficult.
It's going to be very difficult. So if at all you think of regional, what are you going to choose? Are you going to select a single shot subarachnoid block or are you going to choose epidural single shot or graded epidural, or are you going to combine both as a combined spinal epidural? What is going to be your choice? Because you have so many options. Which one will be ideal? First the
I think
ideal, then the practical one.
epidural with a catheter in situ, sir.
Excellent. Epidural with a catheter in situ. What are the advantages?
So we can use that for pain relief also
You can intra-op and post-op pain
and
relief,
post-op
both
also.
can be taken care of, isn't it?
Yes, sir. Yes,
So
sir.
if you put in a catheter, you will be able to manage both ideally in this case. But what are the challenges in managing an epidural in a morbidly obese patient? Is it so easy to perform an epidural in
No,
a
sir.
120 kg lady with the fat overflowing everywhere in the?
No, sir.
No. So what?
No, sir.
How can you overcome this challenge of doing a correct epidural or successful epidural? How do you identify the midline in an obese patient when you want to do a neuraxial blockade?
So if we can trace from above, sir, like from
Where-
C7,
So above above means where from the head
C7.
or
So
C7 cervical vertebra, you can
yes, sir.
drop a straight line. But majority of the times, because of the fat or the posture of the patient, it may go this way or that way. Any other
Yes, sir.
better method is there? That was the oldest method, dropping a straight line from cervical C7 vertebra. Any other technique you know of? Because if you try to palpate the iliac crest and try to identify, that will also be difficult because of the fat,
Yes, sir.
isn't it? The fat
Yes,
will
sir.
be overflowing in the hip as well as in the gluteal region. So palpating the iliac crest itself will be very, very challenging. So what are the recent methods that are very handy to do this, especially in obese patients?
So ultrasound may be a help, sir.
Ultrasound now they use.
Yes, sir.
And 2 days ago, I happened to listen to one talk by a senior anesthesiologist, and he mentioned one method. Did anyone listen to the ICA webinars on Wednesdays? The Indian College of Anesthesiologists webinar is being conducted every Wednesday night, 7 o'clock, 7 to 8:30. So there was a topic on obese obstetric anesthetic parturient. So there they told me I happened to hear a newer technique or a very simple technique used by that anesthesiologist is what he does is he takes a alcohol cotton swab and start touching from one side of the back and just ask the patient to identify whether he is touching the left side or right side. Okay. So you can start from say near about the scapula on the left side and keep on touching every 1 centimeter apart. And by the time the sensation crosses from the left to the right, that is the midpoint. So he makes a mark on that spot where the patient says, now I am feeling on the right, because the sensory distribution changes. So that seemed to be a very, very simple and easy method of identifying the midline. So you start from almost the middle of either right side or left side, keep on touching 1 centimeter gap with the alcohol swab and ask the patient, are they feeling the cold and which side they are feeling? The moment if you start from left side and patient says, I am feeling now at the right, then that is the point where the midline should be, because it has crossed over from one side to other. So that seemed to be a very sensible and easy method of identifying the midline. Okay. And if you have an ultrasound, you have to, any idea how to use the ultrasound for locating the midline in an obese patient? How do you keep the probe? How do you mark the lines? So you have to use the transducer both in the horizontal and vertical plane and mark those lines. And you can see the spinous process, the interspinous ligament, all these things. And then you have to draw two lines, the horizontal line and a perpendicular line, and the cutting point is the point of entry. Okay, you can see, get a lot of pictures in the net as to how to identify the midline. Okay, so that will be your anesthesia of choice. But when you want to administer GA, what are all the problems you have to anticipate and how do you overcome that? So somehow you
problem-
have placed it in a epidural catheter has been cited successfully for analgesia, both intra-op and post-op. And you want to combine it with general anesthesia. So how are you going to manage the GA part of it?
So positioning will go for RAM position, sir.
Very good.
Uh,
First thing, what should you say? Whenever you anesthetize a morbid obese patient, what is the first answer expected in the examination, Viva?
Difficult airway cut should be kept ready, sir.
Excellent. Very good. Along with that, is the cart alone sufficient? Or some man also is required?
Expert anesthetist should be there, sir.
Extra help. By the time you pass out and then once you start training yourself, you will yourself become expert. But however expert you are, always keep a helping hand. Okay, a better knowledgeable helping hand will be a very, very great boon in all these situations. Any difficult case, I think everybody should develop the habit of having a helping hand so that in case of crisis, it will be much easier without raising your BP and tension. You can manage the cases much better. Okay, so but the helping person should be an understanding and a knowledgeable person. Okay, that is the selection of that person is very important. Okay, so two things are required. One is a helping person who has some experience in management of these cases, and a difficult airway cart should be available. And you should have thought about the mode of airway securing the airway well in advance. So how do you plan to secure the airway? What are the criteria and what are all the available modes of securing the airway? Supposing she has got a very short neck and her Malamati classification is 4. You can't see anything beyond the hard palate. Okay? And she has got OSA on top of it. So if all the anticipated difficulty is written on the patient's face, how are you going to plan?
I will prefer awake intubation, sir.
You have to go plan for an awake fiber optic intubation. Okay? So if you plan to go for an awake fiber optic intubation, what are the things you have to tell the patient? Can you just put the patient on the table in RAM position and start doing fiber optic?
So we'll prepare the airway.
Pre-operative preparation.
You have to counsel the patient first. Okay, you have to talk to the patient, explain them why you want to do a fiber optic because of the anticipated difficulty in management of the airway and why securing the airway is very, very important. All that you have to explain to the patient, get their cooperation and consent. They must consent for that also. Okay, and then of course, we will not digress into how to do a fiber optic and all that. So fiber optic awake intubation is a best choice for anticipated difficult airway. But on the contrary, the neck seems to be normal as you see in this particular case, and mouth opening is also adequate. Malambati is grade 2. You are able to see up to a bit of the uvula also. So you think you can manage the case. In that case, how do you proceed? You are not planning for awake fiber optic. You are planning for induction, paralysis and intubation. In that case, what are the steps in securing an airway like that? All of you would have had at least 1 or 2 cases like this in your training period, isn't it?
Don't get
CPAP
start
can
with
be-
pre-oxygenation. Yeah.
So you have
So
to
we
go
can
for
maintain a continuous pressure through the so that even if the patient desaturates, there is a continuous pressure, and so there is oxygenation is continued even if there is desaturation or we are taking time to intubate the patient. So CPAP can be maintained, sir, through a.
Yeah, so first, as Madam said, always start with pre-oxygenation. We always do the regular way of pre-oxygenation for 3 minutes of normal spontaneous tidal volume breathing, or if it is an emergency, you go for a deeper inspiration like 4 or 8 vital capacity breaths. But normally this is being an elective case, we don't have to hurry through like that. So we can hold the mask and ask the patient to breathe aramse in her own way and then try to oxygenate the patient. And to avoid desaturation, in case there is a difficulty after you have paralyzed and induced and paralyzed the patient, there are now several methods to continue the oxygenation without allowing the patient to desaturate, what is called extending the safe apnea period. Okay. So what are all the options you have for extending the safe apnea period? From the simplest to the most costliest.
High flow nasal cannula.
First thing is you put in a nasal prongs and give high flow 15 liters per minute. High flow means you must say the exact liters of oxygen flowing. Okay. High flow
12 to
can be
15
anywhere,
liters.
but nasal prongs you cannot tolerate more than 15. Okay. So 15 liters per minute of oxygen through a nasal prong, even before you start the induction, along with the mask ventilation. Okay. Then what is the next step? Little advanced step. Now, once you are given the induction agent and the relaxant, what will happen to the patient? Will they breathe, or will they become paralyzed and become apneic?
They will go for apnea.
They will go for apnea. Okay. In that apnea, this nasal prongs oxygen, how does it go to the lung? What is the mechanism?
It will
create
a turbulence.
Creates a turbulence. Okay.
Primary supraglottic vortex will be created, sir.
Okay. So that vortex will be circling around the pharynx and supraglottic.
Then cardiogenic oscillations from below, sir. Cardiogenic oscillations from below and primary supraglottic vortex from above.
Above. Are these two enough? Should not there be a negative or a suction effect to pull that gas, because the patient is not taking any inspiratory effort now? So how is the negative pressure at the alveolar level created?
Cardiogenic oscillations.
Cardiogenic oscillations, will they create that? Is it Mubin answering that?
No, sir.
No. Okay,
Difference in oxygen and carbon dioxide grade.
That's what exactly you have to know. See, more of oxygen is taken in and less of carbon dioxide is coming out. So there is always a vacuum or a negative pressure created. Okay. This will suck, or it will help the movement of air from the upper airway to the alveolar level. Okay. The uptake of oxygen is rapid compared to the elimination of CO2. That is how there is a negative pressure created. Okay. So this was what you told about vortex above the larynx and cardiogenic oscillations below the larynx. They are supportive for movement. But the main negative force sucking the oxygen from the upper airway is the difference in the absorption of oxygen and the elimination of carbon dioxide. Okay. For example, if you see, there is 150, 200 ml of air in the alveoli, imagine that. And 150 ml, 100 ml of oxygen is going and only 20 ml of carbon dioxide is coming out. Then there is a vacuum created by this, isn't it? So there, that has to be filled up only from the above. Whatever oxygen is flowing from the upper airway, that has to come and replace that quantity that has been taken up. Okay. This is the main mechanism of what is called apneic oxygenation technique. So you have to mention all the three. The primary mechanism is rapid uptake of oxygen and slow elimination of carbon dioxide at the alveolar level, aided by the moments of the cardiogenic oscillations and the vortex created above the larynx. All of them help in pushing the oxygen downstream to the alveoli and not just stay at the pharyngeal level or the tracheobronchial level in an apneic patient. Okay, so that is the mechanism that you have to understand. So sometimes because of these things are commonly used, the examiners may ask all these things to you. So after the nasal prongs with a high flow, what is the next step? It's called no desat. Have you heard of that? NODESAT, no desat. Then the last mechanism is thrive, THRIVE. Okay. So just to mention all these things, you should keep ready all these things so that you will not land up with a situation where you cannot intubate or you cannot ventilate, right? Then what is so airway problem you have to anticipate and you have to keep every gadget ready. What are all the things that you should have in the difficult airway cart for a case like this? You put in the laryngoscope, you are seeing only a bit of the epiglottis. Nothing else is seen. You are not able to have any vision of the vocal cords at all. Even the arytenoids are not seen. Only a small bit of epiglottis is seen, even though you have thought by examination that everything will be okay, but unfortunately it doesn't happen. So how are you going to manage that airway?
The long blade, especially McCoy, will be useful, sir.
Very good. You can try with a McCoy blade and lift the epiglottis. Very good. One. Then before
Supraglottic airway devices.
no, your aim
No,
is
but you
to
need to
somehow intubate
You
and
just
put a
need to
tube in the
yes.
trachea. So McCoy is a good option. Before that, can you ask your helping person is there, can they do something?
Manipulation, sir.
Cricket patient.
What manipulation you have to do? What is that
Burp
called?
maneuver.
Burp maneuver, yes. Backward, upward,
Backward,
rightward
upward.
pressure. First thing you have to do that. Okay, ask your helping person to. What usually normally I do is I will try to adjust by
Can't hear you, sir.
Sir's voice is lost. So what you can do is once you try to put the laryngoscope and see, and you're not able to see anything other than the epiglottis, you manipulate with your right hand and get the glottis to visualize the glottis, and then you take the assistant's hand, hold it in the same position. There's no point telling them. You can't tell them hold it here, hold it there like that. So if you keep it and put their hand in the same pressure, same point, then they'll be able to help you much better. I'm sure that's what Sir's trying to tell you. His voice is lost, isn't it?
No.
Sorry, suddenly my connectivity was lost. Am I audible now?
Yes, sir. Yes, sir.
Yes, sir.
Okay, okay. I'm
Yes,
extremely
yes, sir.
sorry.
Yes, sir. Audible, sir.
I don't know why suddenly this problem happened.
Network issue, sir.
Network issue. Okay,
Yeah,
right.
yes, sir.
So burp maneuver, McCoy laryngoscope. Okay, by doing this, you are able to see the arytenoids alone. Still, you are not able to see the entire vocal cord. What is the next step you can do? Who has been answering this so far? Who was answering? Monali. Monali, were you answering? Monali Thakur?
Yes, sir.
Okay, good. Now you have used either burp maneuver or McCoy laryngoscope, but still you are able to visualize only the arytenoid cartilages. You are not able to see the entire vocal cords. So can you pass the tube just looking at the arytenoids alone, or do you have to do something here? Can you
What
use
are all the
any
accessory
instrument?
devices? What
Hmm.
are the accessory
sir.
devices?
Boogie.
Bougie, yeah, think of the bougie. Okay, bougie is a very, very life-saving instrument. So you can think of the bougie, just try to insert the bougie through the, just above the arytenoid, whatever you are seeing, imaginary opening will be there. You pass it through. Many a times you will be successful. And once you pass the bougie, then railroad your tube through that and then complete the intubation. Okay, so all these things you should have planned. You should have planned whether to go for an awake intubation, fiber optic, or whether you have to go for induction intubation. And if you are going to make the patient unconscious and paralyze them, and what are the methods of securing in case you have difficulty like this. Okay, all these things should have been planned and kept ready. You should not be struggling to get a bougie at the time and then shout at the theater assistant. All that should not be done. Okay, so everything should be meticulously planned. Right, airway has been achieved, secured. So what is the maintenance? Which is the best induction agent you would prefer for an obese patient? Please answer quickly. We have to finish the class. I can't be waiting for these answers endlessly. Regular GA, whatever drug you are using, I'm asking the same question only. I'm not asking anything new. Hmm?
Propofol.
Propofol, why so much of delay in answering this? This is nothing abnormally I'm asking. Propofol is the best agent. Why propofol is the best agent? Whether it is obese or non-obese, why we are nowadays prefer to give propofol rather than the older drugs like tipentone or etomidate? See, these are all common questions. They first test your basic knowledge and then only go for questions which are more difficult. So you should not have any hesitation in answering these basic questions. You should all come out rapidly. Okay. Don't waste time thinking long time. If you take, they will think that you have not learned your subject properly. Okay. So propofol, what is the reason for the current preference of every anesthetist to use propofol instead of the older agents? What are the
Short acting,
advantages?
sir.
Huh?
Short acting, sir.
Short acting. Is it short acting than your other agents? Is that the reason? Smooth induction, better depression of the respiratory reflexes, okay, and good smooth recovery. Patient will wake up nicely without any residual or hangover effect. Okay, these are all the advantages of inducing a patient with propofol. Right. So what is the relaxant of choice? How will you decide what relaxant you have to use for intubation in these cases? Supposing, as I told you, you think that you can intubate this patient easily, but in your back of your mind, there is also a small doubt whether you may have some difficulty after putting the scope. So if that doubt is there, what is the relaxant you will choose? On the contrary,
Succinyl codeine, sir.
succinyl choline, yes. If you have any doubt about the easiness of the intubation, you always go for scoline because it's short acting and patient can come out of the relaxant faster. On the contrary, if you are quite confident of intubation, then you can straight away go for a non-depolarizing muscle relaxant. This is the basic dictum you have to know about management of airway. Okay. Is there any, supposing it is via media, you are neither 100% sure that you can easily intubate, at the same time, you cannot confirm and say that you may have some difficulty. In that case, any preliminary test with which you can decide which relaxant to take, whether depolarizing dexamethasone or non-depolarizing muscle relaxant.
After giving the induction agent, can you do something?
Have you heard of trial laryngoscopy?
Yes, sir.
Yeah. What do you do in trialscopy?
Before giving the relaxant, we'll just have an overview of the airway, sir.
You can put in a scope, okay, nicely lubricated with silicone jelly at the tip so that you don't stimulate the airway, and try to visualize the oropharynx. If you are able to see even a small bit of your epiglottis, then you can definitely intubate that patient with a relaxant. Okay, so before relaxant, if you are able to visualize after the induction or even in a conscious patient, that's what I always do. Put the scope and see what is the maximum vision you get inside. So if you are able to see even a small bit of your epiglottis, you can boldly give a non-depolarizing muscle relaxant, comfortably paralyze the patient and intubate the patient. Okay. So that is one of the practical tips which is not given in any book, trial laryngoscopy before giving the relaxant. Okay. Right. So all these points you have to discuss with the, in case if they ask you about airway management. What are the other important challenges in managing or giving GA to a obese patient? What about the drugs? How do you choose the other intraoperative drugs? On what basis you will choose? This is a very common question in obesity patients. What drugs you will choose on total body weight basis? What drugs you will choose on the so-called ideal body weight or lean body weight
Sir,
basis?
induction agent and muscle relaxants are based on total body weight. Benzodiazepines and opiates are based on ideal body weight, sir.
Very good. So all that you have to read about and know all those things. Okay. Then what about the fluids? Whether you give it on total body weight or at the ideal body weight.
Ideal body weight, sir.
How do you calculate the ideal body weight? Unless you know what is the ideal body weight for the patient, how do you
Height
administer?
minus 100 in male
Hmm.
and height minus
Height in
105
what?
in female.
Height
in
in
centimeters.
what? Centimeter. Always say the measurement also. Okay. 170. This lady is 172 centimeters. So 172 minus 105 for female. So her ideal weight is only 67 kgs, but she is 120 kg. Okay. So all these things should have been calculated and kept ready, right? Okay. So I'll go back to the presentation. Oh, even that is gone. Okay. 1 second. I'll have to. Thing got disconnected.
Visible, sir.
Visible, okay. So, for want of time, I'm just, I'll go through the, so this is the case scenario we have seen. So for your convenience, I have myself made out the list how to go about these cases. So 32 years old, 120 kg, 175, calculated BMI for me came as 39.18. So patient definitely belongs to class of severe obesity with added DM and features of obstructive sleep apnea. Scheduled surgery is cosmetic in nature. Now, preoperative evaluation, what is the cause of obesity, whether it is genetic or unhealthy lifestyle or any other, and what is the duration and severity of OSA, whether any treatment like CPAP or BiPAP has already been instituted or whether it needs to be investigated and started, detection of DM, whether it was based on the patient's complaints or on a routine checkup, any dietary adjustments tried to correction or started straight away on oral hypoglycemic agents from the beginning. And then what is the follow-up after that starting of treatment, whether the sugars came under control, whether the HbA1c was periodically checked, and possibility of metabolic syndrome. Whenever an obese patient also has diabetes, you have to think of metabolic syndrome. And system-wise, you have to go for airway thorough examination, and in the CVS, you have to rule out hypertension, ischemic heart disease, atherosclerosis. RS, they may have restrictive lung disease. In the GIT, they may have fatty liver. They may have GERD also. Gastroesophageal reflux diseases and hiatus hernia are very common. And examine the renal function, metabolic functions, whether any history of hypoglycemia or hyperglycemia with ketosis, musculoskeletal, whether any joint problems, and make all anthropometric measures. And then investigations, all the routine investigations you do, plus polysomnography, if they have not done that, calculation of ideal body weight and lean body weight for drug dose calculations. This should have been done in the preoperative assessment itself. And intraoperatively, you ideally manage by a specialist team of anesthetists trained in obesity anesthesia. This is the guideline given by the British Society for Obesity. So each hospital should have a designated anesthetist and a team to manage the obese patients, especially supermorbid obese patients. So you can remember the problems are airway, positioning the patient on the table, monitoring how you are going to monitor, because tying a beefy cuff or putting the ECG lead, everything may be difficult in these patients. And what are the agents that you are going to use for intraoperative maintenance of anesthesia, and what technique you are going to use, whether GA or regional, how are you going to manage the pain, and fluids, how are you going to administer and what fluids you have to give. And for drugs, you have to, which drug have to be given on ideal body weight and which drugs you have to give on total body weight. And DVT prophylaxis also very, very important in this obese patient. Then post-operative management, you have to go for extubation in the head-up position with the patient wide awake with all reflexes recovered, use of CPAP machine immediately after extubation in some cases, and early ambulation and continuation of DVT prophylaxis, and as far as possible, usage of opioid-free analgesia, because these patients with OSA are very sensitive to opioid analgesia. So try to avoid opioids and go for non-opioid analgesic drugs. So, so what are the other things you have to learn before the exams are pathophysiology of obesity, details about polysomnography, how is it done, and what are the components of metabolic syndrome. And supposing the examiner suddenly leaving this case scenario, ask how will you do a bariatric surgery for this patient? That details also you should be able to answer. Okay, bariatric surgery is mostly done as a laparoscopic procedure, and the basis of bariatric surgery is to reduce the intake by decreasing the capacity or volume of the stomach so that the patient feels satisfied or satiated with a small amount of food intake. So now gradually over a period of time, their food intake will come down and they will become lean, losing all the extra fat. That is one problem, one method. And second indication is sometimes the obese patients become diabetic, which is not controlled by your regular medications or even insulin. So in those cases, bariatric surgery seems to have a good effect in controlling their metabolic and diabetic state by reducing the intake. Okay. So nowadays, apart from the weight reduction, another indication for bariatric in obese patient is uncontrolled diabetes, even with insulin. So this is the newer thing that you have to know about. So these are all the points that you thought it will be easy for you. Now coming to the second case scenario, this is 24 years old primary gravida, 34 weeks of amenorrhea, admitted with severe headache and visual disturbances. BP is 180, 110. She was diagnosed to have elevated BP at 26 weeks during antenatal checkup. Was diagnosed as a case of pregnancy-induced hypertension and started on nifedipine 10 milligram BD. How to manage and proceed with this patient? So the 34 weeks, what trimester is it?
Third trimester.
Third trimester. Third trimester. So in third trimester, patient is admitted. She has already been diagnosed with high BP at 26 weeks. Okay. So is it a pregnancy-induced hypertension or some other? What are the types of hypertension associated with pregnancy? How do you classify the hypertensive disorders of pregnancy? This is a common question that you will first get about if you get a patient.
Gestational hypertension, overt hypertension, gestational hypertension with pre-eclampsia, gestational hypertension with eclampsia, and chronic hypertension.
Chronic hypertension.
Gestational, you are giving new classifications. Okay. So chronic hypertension is one which is present even before the lady has become pregnant. Okay. And that patient, if they become pregnant and then they get features of preeclampsia, that is called preeclampsia superimposed on chronic hypertension. Okay. Whereas there are two categories, what is called pregnancy-induced or gestational hypertension and pre-eclampsia. What is the difference between these two conditions? So there are totally four classifications. One is patient could have been a hypertensive before pregnancy. That is called chronic hypertension. Then they develop hypertension after 20 weeks of pregnancy during the first trimester and after 8 weeks of the first trimester until second trimester middle time, normal BP is there. So BP becomes high only after 20 weeks of pregnancy. That is called gestational or pregnancy-induced hypertension. Okay, but if some change takes place along with the high BP, then you call it as preeclampsia and not pregnancy-induced hypertension. So what is the difference between gestational or pregnancy-induced hypertension and preeclampsia?
Gestational with proteinuria.
Proteinuria, simple. These are all points which you have already studied and known. You have to bring out one quickly in the exam. That's all. That's the reason for this training. You are not trying to find out how you know what you know and all that. Okay? So the ability to immediately recall and reproduce in the exam, that is what is needed to pass the exam. Okay? So if there is associated proteinuria along with hypertension, it is preeclampsia. It is not simple pregnancy-induced hypertension. Whereas gestational or pregnancy-induced hypertension, till the time of delivery, there should be no proteinuria in the urine. If proteinuria happens, it will become preeclampsia. Okay? And along with that, if the patient throws a fit, it is called eclampsia. Okay? These are all the things that you have to know. So here, now the patient has got severe headache, visual disturbance, BP is high, but the original diagnosis PIH, that is pregnancy-induced hypertension. So we take it for granted that there is no proteinuria and it is only a simple gestational hypertension. But this severe headache and visual disturbance, are you willing to accept that, or should we do something about this? it is so disturbing to the patient that she has come to the hospital. She is not able to bear the headache. She is having fireflies flying all over the place. Her BP is very high. So with all this, when she comes, should not we interfere and do something, or just we have to ignore
So
and ask
these
her to
are
go?
features of pre-eclampsia and impending eclampsia also.
So we are worried about that. So what should you do at this stage? The question is how to proceed. Now you are in the emergency, madam, and the patient comes with all these complaints. You have found out that she is now 34 weeks pregnant. She has got all these features. Now I am asking you, what are you going to do? What is your answer?
So magnesium sulfate can be started. Discharge within the
IV
room.
So you
antihypertensives.
will give all that as a OP and send the patient home?
First
So
admit
we'll
the patient, right?
First
we'll
thing,
admit the
admit. That is the thing. You know, even though you are not going to do admission, you have to tell your OG colleagues to say that please admit this patient. Physician automatically they will admit this patient. They will not ask them to go home. Okay. So first admit the patient, check the BP every 2 hours. Then, as you said, you can start magnesium sulfate. You can start antihypertensives, and follow up both the mother and the fetus. Okay. In case the BP is not responding, the BP still has a tendency to increase further. Say from 180, 110, it goes to 200, 110, 130. What should you do? Or what should the physician do?
Terminate the pregnancy.
Why? You can terminate the pregnancy. Is it safe to terminate the pregnancy now at 34 weeks?
With a proper NICU, it can be done.
It can be done. Proper NICU is a little difficult, but is there a possibility that when will be the ideal time to save the fetus in case you are more interested in the welfare of
Lung
the baby?
maturity,
36.
fetal lung
6 weeks.
maturity.
At
After
what?
36 weeks.
After 36 weeks.
After 36 weeks, it is safer. Okay. So,
Dexamethasone should be given.
without compromising the mother's safety, if you can wait till 36 weeks of amenorrhea, it is very good. Okay. But the primary concern is always about the mother. So if the BP gets controlled with the treatment that you start, don't rush to terminate the pregnancy. Allow the pregnancy to continue till 36 weeks and then take a decision whether you can allow it further and wait for till the 40th week or the full term. If the patient feels better symptomatically and the BP is well under control. On the contrary, if the BP is not getting under control, if there is any worry about the mother's life, then you have to terminate the pregnancy by either operative delivery, or can you permit normal vaginal delivery even at 34 weeks or 36 weeks? Is it possible to take a decision like that?
No.
There is no cephalopelvic disproportion. Everything seems to be all right. So in that
The
case,
stress of labor will not be.
can
it
you
will
be of
increase
help in helping the
Induction of-
lady to have a normal delivery?
Induction of labor can be tried, sir.
Induction of labor? No,
Can
I
we-
give you a scenario. She is admitted at 34 weeks with severe headache and all these complaints. You start magnesium sulfate, you give IV antihypertensive agents. BP comes back to 120/80 and she is comfortable. So you just observe her and keep her in the ward. 2 weeks gone by, 36 weeks. Now she is comfortable. She is not complaining anything. And you want to proceed and have a normal vaginal delivery. Can you allow her to go for a normal delivery?
Yes, sir. With epidural, walking epidural, we can.
What is the worry about it? The pain, labor pain is going to shoot up the BP again. That is the only concern for us, isn't it? So as anesthesiologists, we can think of labor analgesia to control the pain, and if all the other parameters are okay, normal delivery will be good any day than a cesarean delivery, isn't it? So if you can control the pain of labor, and if the parameters like cephalopelvis measurements are all normal, conducive for a normal vaginal delivery, definitely a normal delivery can be tried with the epidural analgesia. On the contrary, if there is any risk for the fetus as well as the mother at any time, immediately go for cesarean section. Okay, so that is what you have to know about. And if you are going to take it up at 34 weeks itself, since the patient is not responding to your treatment, then as somebody said, you have to give dexamethasone for lung maturity, have all facilities for management of a preterm baby, which may be have to be kept in the neonatal ICU and taken care of by a neonatologist experienced in management of preterm babies. Okay, so these are all the points that you have to remember. So I'll go what I will. This 26 years old, she's a primee by pregnancy-induced hypertension, diagnosed at 26 weeks, and patient is on nifedipine. Now at 34 weeks, sudden increase in BP with headache. Now the dilemma is maternal versus fetal safety. That is the major decision that we have to take, or the physician has to take. In pre-op evaluation, whether the patient had regular checking of the BP from the initial diagnosis, whether she was regular in taking the medications, any urine protein test done, does she have any other problems like hypochondrial pain, or to check whether there is any features of HELP syndrome, or assess fetal welfare by daily fetal movement count, non-stress test and biophysical profile scoring. This is for mainly fetal welfare. So the main decision to be made is whether to allow the continuation of pregnancy to help more maturity of the fetus up to 36 weeks, or deliver the baby at this stage itself, even though it may be premature, to prevent pre-eclampsia in the mother. So it depends on the condition of the mother. So mother should be admitted to control this hypertensive state and observe for any features of pre-eclampsia. Early magnesium sulfate therapy will help both control the BP and prevent any seizure activity in the mother. Then investigations, all routine urine protein, creatinine ratio, specific gravity, epithelial cells, RBCs, all these things have to be done. And liver function test, coagulation profile, and fundus examination to be done. Management, if normal labor is safe and permitted with adequate pain relief from early stage of labor. If operative delivery, regional anesthesia with modifications like low dose spinal with opioids, or combined spinal epidural, or titrated epidural with a catheter, these are all the choices. But if you have to go for GA, control the BP during induction and intraoperative to prevent cerebral bleed, which is the main cause of maternal mortality in these cases. So all protection to prevent the rise in BP or sympathetic stimulation due to laryngoscopy and intubation has to be taken. So what are the other things you have to know is physiological changes during pregnancy, pathophysiology of all types of hypertensive disorders in pregnancy, and features of HELP syndrome. So these are all the side tracking questions that may be asked in the examination. So you must be ready to answer all these things, even though the case scenario given is a PAH case. Okay.
So in the investigations itself, I think they have to mention serial platelet checking, sir.
That is
Yes,
coagulation profile we have said. And of course, if the patient is specifically, you have to say about
platelet
coagulation. And if you are using magnesium sulfate as a measure to treat the hypertension and as a prophylaxis against eclampsia, you have to be careful when you give GA with a non-depolarizing muscle relaxant. You have to be. And common questions about magnesium sulfate: what is the safe serum level? What are the various levels at which various disturbances happen, like loss of tendon reflex, respiratory depression, cardiac arrest, at what levels it happen, what are all the mechanisms of action of magnesium sulfate, what are the other uses of magnesium sulfate, everything can be asked. So you must be thorough with your knowledge on magnesium sulfate. That is very, very important. Okay. So these are the two major cases which have been discussed in a very short form. Now I am showing some short case scenarios. Can anybody identify this?
Previous equinovarus, sir.
Bilateral or unilateral?
Bilateral.
Always you must mention that. It's a
Yeah.
congenital bilateral talipes equinovarus. So what is the treatment for this? When do you start treatment? If it is present from birth, when do you start the treatment?
Treatment is stage wise, sir.
Stage,
According to
very good. Yes.
initially they apply cast, then there is they
What age? What age did they start? That's what I want to know.
age I'm not sure, sir.
As early as possible, before the child starts walking or trying to get up. Okay. So yeah, they start treating this by conservative methods, by putting it in normal position and trying to apply cast. They will try as early as 2 to 3 months itself. Okay. And serial plaster castings will have to be given. By the 9th month, most of the cases will get corrected by this conservative method of treatment itself. But if neglected and not attended early, then they go for permanent contracture like this. Then they require open procedure. Okay, so they may need either a tendo-Achilles stenotomy or they may require open soft tissue release. That is the procedure that you have to give. Supposing a 1-year-old baby with severe talipes not attended at as a earlier, younger age, comes for soft tissue release because it is not, or failed conservative management. However much you try to put the cast, it is not getting corrected. And ortho surgeon decides that it has to be only operated and fixed in correct position. What anesthesia can you think of for a 1-year-old child coming for soft tissue release and correction of talipes? What are all your options for anesthesia?
So, general anesthesia without intubating, so mass ventilation can be done. So it will be a short procedure.
That is stenotomy is a short procedure, but open release
is
in
not.
the soft tissue is not a soft procedure. It may take 1 to 1.5 hours easily, because they will make an incision, along this line, and then open the tissues, go to the talus bone, remove some part of the bone, and then try to, in the inverted foot will be kept in everted position. Sometimes they may put some pins also. That is not a short procedure. What you talk about short procedure is stenotomy. That can be done percutaneously. That, as you say, it's a easy procedure which can be managed with mass ventilation and some analgesia. But if it is an open procedure taking about 1 to 1.5 hours, what will you do? Can go for caudal epidural and always think of caudal epidural in children. What is this condition?
Unilateral varicose veins, sir.
Unilateral, or don't you see varicosity here?
Yes, sir.
This is very prominent. So don't go carried away by that.
Because this was bilateral, she said that's better to say unilateral.
Yeah. So bilateral varicose veins leg. Okay. What is the treatment for this?
Siphonofemoral junction ligation, sir.
Very good. Along only venofemoral.
No, sir. Sclerosant.
Nowadays they do sclerotherapy.
Sclerotherapy, sir.
But older treatment is stripping. Stripping of the varicose vein. So they will put a long wire and then tie it at the femoral junction and then pull it by, the whole thing will be stripped off. What is called stripping of the varicose vein. Okay. So what anesthesia I can give for that?
Very simple. Just say spinal. Why you?
Everything you are taking time. Exam you cannot take so much time. Okay. This is a 4 months old infant with a machinery murmur at the left upper sternal border where they are auscultating. So what is the cause of that machinery murmur? Machinery murmur?
PDA.
PDA, patent
Patent
ductus
ductus arteriosus.
arteriosus. Okay. So will patent ductus arteriosus be open till 4 months?
No, sir.
No. When should it close in a normal healthy child?
By 2 months of age.
There are two types of closures, sir, anatomical and functional.
Hmm.
Functional will close just after birth, sir. Anatomical will take 2 months. Not,
2 months is too long a time, I would say rather. Okay. Anatomical and functional closure. Functional closure anywhere between 72 hours to 1 week. Even immediately after birth, majority don't close. So 72 hours to 7 days is the normal functional closure itself. Until such time, you may be hearing that murmur. But the entire thing to fibrose and completely become obliterated, it may take about 1.5 months to 2 months. Okay. But the murmur will disappear after 1 week, usually. But if it is still persistent at 4th month, what does it indicate? It is a patent ductus arteriosus. Okay. What are the dangers of, or what are the harmful effects of persistent patent ductus arteriosus? What can it lead to in the long run?
Pulmonary hypertension.
Yeah, it is going to be left to right shunt. So there is a volume overload into the pulmonary circulation. So over a period of time, pulmonary vessels will start fighting against that overload. They will become hypertensive. So the pulmonary hypertension will affect the right ventricle ejection. That will fail. Okay. So it will be a volume overload complication on the pulmonary circulation. So pulmonary plethora will be there. Patient may go in for recurrent respiratory infections.
recurrent infections.
Okay. So what anesthesia you will give for, what is the surgical treatment for this? Or what are the treatment available for persistent PDA giving problem like raising the pulmonary pressures and all that? What can you do?
Is there any medical problem? Is there any medical treatment? that we
Prostaglandin
can give?
E1, sir.
That will try to close or open.
Prostaglandin E1 is given for a different purpose.
COX-2 inhibitors will close the PDA. COX-2 inhibitors, sir. Indomethacin will.
Indomethacin.
So that is a treatment which majority of the times may not help in cases like this, where there is a persistence of this communication. So what are the other options apart from the drug therapy?
PDA ligation, sir.
That is surgical. Any interventional procedures? Nowadays, everything, radiologists or cardiologists, they try to do without surgery. Even the day before yesterday, within 9 hours, they have done mitral clipping and trans-aortic valve repair in 9 patients in a city hospital. Are you not reading the papers? So everything is now going towards interventional procedures rather than open surgical procedures. So you can try to ligate or occlude the communication by balloon. Okay. Or if that facility is not available, then you go for open surgery ligation of the PDA. Is it a sternotomy procedure or thoracotomy procedure?
Both ways it can be done, sir.
Both ways. Which hospital
No.
they do? Which hospital they do thoracotomy? I mean, sternotomy for a PDA ligation.
Is it a closed heart procedure or open heart procedure?
It is usually done by thoracotomy itself, okay? And it can be done with a beating heart. There is no necessity to go to cardiopulmonary bypass and all that. Okay? What is this you are seeing? Is it visible clearly?
Phimosis?
One-year-old boy with a tight phimosis. Okay. So what anesthesia you will give for supposing pediatric surgeon wants to do a circumcision? How will you anesthetize this baby? 1-year-old baby for circumcision.
Caudal plus sedation, sir.
Caudal sedation, penile block, GA with mask ventilation, GA with intubation. Okay. All these things are the answers for that. Right. What is done here?
Ankle block.
Ankle block,
Is it entire ankle block or any particular nerve for
No,
the
it's not.
medial tibial tibial nerve, sir.
medial tibial? There is no medial
Oh,
tibial.
sir, sorry, sir.
Posterior
Posterior
tibial.
tibial, sir.
Yeah.
Posterior tibial, sir.
So they are trying to do a US guided ankle block where they are blocking the posterior tibial nerve. What are the other nerves to be blocked for ankle block? What is their distribution or supply area?
Staphenous nerve, sir. Sural nerve.
Uh,
Anterior tibial.
No anterior tibial. This is posterior tibial. Peroneal, superficial peroneal and deep peroneal. Totally
peroneal.
5 nerves.
5
Okay. Tibial, that is posterior tibial, superficial peroneal, deep peroneal, saphenous and sural. And these are all the areas which are supplying. And this particular, this what is called the deep peroneal nerve supplies what is called the web space of the first and second toe. This is a very common question they will ask. What does this deep peroneal nerve supply? It supplies a very small portion between the first and second great toe and the second toe, both on the plantar aspect as well as the dorsal aspect. The only nerve supplying there is the deep peroneal. All other is superficial peroneal. And the entire dorsum up to the lower part of the anterior part of the leg, it is the lateral part of the foot is sural, and medial malleolus and above is saphenous, and the entire plantar area is by the posterior tibial. Okay, so these are all the distributions you should be able to say. Now, can you perform ankle block for this case? This is an infected wound which is there. Is it possible to do some debridement using local anesthesia in this case?
Local anesthetic might not work, sir.
Why? That's a common question. Local anesthetics not work in the affected area.
Acidic.
What acidic? What is acidic and what is acidic? See, all the answers you should know very clearly. You should be able to explain everything in one shot so that there is no further question asked by the examiner. Okay. So, if you know the mechanism of action of local anesthetic, then it is very easy to answer this question. So, how does the local anesthetic act?
So, to pass through the lipid membrane, it has to be in a non-ionic form.
Very good.
But when it's an acidic medium, the ions dissociate and they cannot remain in a non-ionic
They cannot
form.
penetrate. Okay, so first they have to penetrate the lipid membrane of the axon, then enter the cytoplasm of the axon, and once they enter the cytoplasm, they have to break down into their ionic components and block the sodium channel from inside the cytosolic aspect, so that there is no entry of sodium from outside when there is an action potential coming. That is the basic thing that every anesthetist should know. So to enter the axon, you require unionized or non-ionic form. Better to say unionized rather than non-ionic. Unionized form is only will be able to. I usually tell the example of, see, all of you may be having the habit of going to pubs. In sub-pub, so they will allow only couple to come in. Okay, so you have to go in as a boy and girl together, go inside, and then you can change your partner. You can separate and then go and dance with somebody else. Like that, when you want to enter the nerve, the local anesthetic has to go as a couple. Once they go inside, they separate and then go and block the sodium channel and try to prevent the entry of sodium. Okay, that is how it acts. And because it will not get It will not remain in the unionized form in this pH medium, which is more acidic. It cannot, first of all, enter the nerve at all. And the second thing is there will be a lot of edema, where if you inject the solution there, the concentration will get further diluted, and again that may not be sufficient to block the nerve. Okay, so these are all the reasons why it will not take up. Is nerve stimulator useful for doing an ankle block? Is there any motor component in any of these nerves? They are all sensory. So only when there is a motor component, you can use a nerve stimulator so that you can elicit a motor response. Otherwise, nerve stimulator is useless. That's why they are using ultrasound guided. Now I am going to show you a few ETCO2 tracings. So what you are seeing is the waveform in a patient with shock and alveoli leak. This is a very common tracing all of you would have seen. In which condition does it happen? Seen in bronchospasm, shark fin appearance. Okay. This is another capnographic tracing. Where do you see this? Does it look normal or slightly abnormal?
So, inspiratory valve incompetence.
Huh?
Inspiratory valve incompetence.
No. See, normally it should stop here and then the exhalation start. There's no hump like this, isn't it? See, all this. Here also you are seeing this is the classical wave or tracing. So it goes here, one angle is formed, here is one angle is formed. So whereas here there is a peaking. So this happens in poor compliance of the lung due to obesity or pregnancy. Okay. What is this? The tracings are very small here. Now it is trying to become bigger. In which condition you will have that? Initial tracings are small. Suddenly it starts becoming normal. Return of spontaneous circulation. So now there are 4 waveforms shown here. Capnographic waveform shown during advanced airway placement. That is, when you try to intubate, you get 4 waveforms like this: 4A, 4B, 4C, and 4D. You must say what are all the various things that are happening in these waveforms. In this one, the waveform starts only here. Before that, there is nothing. So what has happened here? Initially, tube has not entered. Now, once the tube enters, you start getting the waveform. Okay. But here the waveform is there, but the normal angulation is not there. Here, does it look normal here? 4C. It's a normal pattern. And 4D, there is a normal pattern, but suddenly it again becomes what is like this. Okay. So if you see all the explanation, the patient is apneic here, but normal wave is beginning later on. Patient has started breathing. In 4B, airway has been secured, but not properly. Some leak is there, so the normal tracing is not coming. In 4C, it is happening as a normal waveform. And 4D, after a normal waveform, suddenly it again goes like a apnea pattern, which is either arrest or a disconnection. Okay, so the tube is not properly connected, or patient is arrested and there is no waveform because there is no flow. What is this? Where the waveform is normal here, becomes slightly reduced, still getting reduced here, whereas here it is starting as a small and then becoming bigger and bigger and bigger. What is this condition? What is this condition? See, ETCO2 first to 40, then becomes 35, then becomes 34, then becomes 30.
Hypoventilation.
Hyperventilation. See, when
This
it
is hyperventilation.
whereas when it starts increasing, it is hypoventilation. Okay, so hypo and hyperventilations. Right. What is seen in this picture and what is the difference? In one person, there is some reddishness.
Hypersensitivity, urticaria, sir.
Should be
So
angioedema.
different forms of allergic reaction. One is a cutaneous allergic reaction. Second is an angioneurotic type of anaphylactic reaction. So first is a mild cutaneous one. Next is a severe angioneurotic type. What is shown here and how to use it. Of course, these drugs are not available in our country, but just to make you aware that these drugs are available in the Western world, especially for patients with known allergy who have to treat themselves in case of emergency. So the name of the drug is written here. If you see the picture, always in Osce questions, you should look at the picture clearly and try to identify, read it, and then try to take a call on that. So this is, what is the drug that is present in this?
Injection epinephrine.
Epinephrine. So it is called EpiPen Junior, EpiPen 2 pack. Okay, JR means junior. So the quantity is 0.15 and 0.3. So pre-filled syringes with 2 different doses of epinephrine for self-administration. So Western countries, they tell the patients, they very commonly they get a lot of food allergies. So at home they may get this sort of picture. So the physicians ask them to keep these drugs ready at home and they can inject themselves. So this is called EpiPen. 2 doses are there, 0.5 and 0.5 and 0.3. And less than 22 kg, you have to give 0.15. More than 22, you have to give 0.3. And that can be given as a subcutaneous injection. So what is the first line of treatment for anaphylaxis and why? It's a common scenario that will be given in your exam. And this knowledge is very important because once in a while, unfortunately, you may land up with a patient having an anaphylaxis like for any of your anesthetic agents. So unless you know what is the treatment, you cannot save the patient. So epinephrine, IM or
First of all, we have to maintain airway, breathing and circulation, followed by injection epinephrine, sir.
First line therapy.
And
the reason why is it has got all alpha, beta, all results. So increase vascular resistance, decrease in mucosal edema, increase in inotropy, chronotropy, and bronchodilation. All these things are there. What is shown in this picture? Blood is taken out from the body, something is done and then reintroduced into the body.
it's a venous ECMO, sir.
It's an ECMO. It can be veno-venous as well as veno-arterial. Both are shown here. Okay, so extracorporeal membrane. So there are 2 types, veno-arterial and veno-venous. So what is veno-venous used for and when do you use veno-arterial?
Veno-venous is only for oxygenation purpose.
Lung saving. Okay. Arterial for both cardiac. Okay. Support of lungs and heart, you go for veno-arterial. Its uses. Where do you use them? What are the indications for putting a patient on ECMO? Last year, COVID, many hospitals tried. COVID is one of the conditions, okay?
Yeah.
So hypoxic or hypercapillary respiratory failure, refractory cardiogenic shock, failure to wean from cardiopulmonary bypass, as a bridge therapy before cardiac transplant or lung transplant, septic shock and hypothermia. Okay, what are the complications of ECMO? Any invasive procedure, you require heparinization. So if you can lead bleeding, neurological insult, heparin-induced thrombocytopenia, inability to wean, all these things are problems. Can you identify this person? He has made a big contribution for Airway. That's the clue I can give you. Archie, does he look like a Westerner? Is
Mallam-
Seshagiri Rao
Mallampati.
Mallampati. He's a Andhra Pradesh man who settled down in first went to UK, then from there went to Canada, and from Canada only he published his paper of Mallampati classification. Okay, so his contribution is Mallampati scoring, which we are till today using it. Okay, so what was his original description? How many classes of Mallampati scores were there, or grades? He described only 3 grades, okay? And then somebody modified that to 4 grades, what we are using now. Who are those people? It's all some of the history which you should know. Samsoon and Young modified his classification and added a 4th class. So original Mallampati 1 to 3 grades, modified 1 to 4 grades. What is upper lip bite test and who proposed it? This is a recent test added for airway assessment. What is that? How do you do the upper lip bite test?
Ask the patient to bite his upper lip, and then we'll see the level at which his teeth reach. If it is beyond the, it is classified according to that only, sir. Alveolar, that margin of the lip, or it is below and above the lip margin.
Margin, you don't call that as a margin, you call it as
Vermilion line.
a white line, white roll or vermilion line. So above the vermilion is normal grade 1, at vermilion is grade 2, below the vermilion grade 3. Okay, so and it was proposed by Khan ZH et al. In 2003. Khan, remember Shah Rukh Khan, Amir Khan, Salman Khan. So remember Khan. It was decided by not those Khans, but this is different Khan. Don't say Salman Khan in the exam and spoil my name. Just for you to remember. What is shown here and where are they used?
Insecticide, organophosphates.
Organophosphates used as pesticides. Okay.
Yes.
What are the symptoms of OPC poisoning? One of the repeatedly asked theory questions.
Sir, it can be easily remembered by sludge.
Very good.
Salivation,
Excellent.
lacrimation,
Yes.
amplification.
Excellent. Okay. So it acts on the so many receptors on the parasympathetic system, nicotinic and muscarinic receptors. And the mechanism of OPC poisoning is remembered by this word sludge. And so treatment is you have to decontaminate the patient, give atropine, and to release the binding with cholinesterase enzyme, you have to give oximes. Okay, correction by metabolic abnormalities. What do you see in this EKG? Is there any continuity between P wave and QRS complex? Are they following a P wave correctly?
So P wave, not all P waves are being followed by QRS complexes.
So what do you call that?
So it's a heart block.
Yeah, it's a
close to
complete
one
heart block. Very good. So what is the atrial rate and what is the ventricular rate? How do you calculate the atrial and ventricular rate in heart blocks? So atrial rate is 85, ventricular rate. So always you have to take the long strip and then count the number of QRS and multiply it by 6. Okay.
Yes, sir.
What is the treatment? Insertion of pacemaker. Okay. Yes. And what lead you have to choose is by this method. So if the sinus node is normal with the AV block, then go for VDD. That is, the pacing is ventricle, responding is ventricle. Then third is also, dual and dual. Whereas here, all dual with a rate modulation, permanent atrial fibrillation, VVAR. These are all the names by which you go. What is seen in this X-ray? Little bit quick. I'm leaving for outstation today at 8:30. My train is at 8:30. So I'll rush through. Bowel shadow seen in the thorax with the discontinuity of the left diaphragm. So what is the usual cause of this? Is a blunt injury to the abdomen, most probably motor vehicle collision. So its affected side is left side, mostly because that is the common area where you will get the injury. And the posterolateral aspect, that is the Bodak area of herniation. So the signs and symptoms will be pain, difficulty in breathing, and you can have a resonant note on percussion, and also you can auscultate the bowel sounds in that. And the symptoms appear within the first 4 hours. After that, it gets settled. You will not find it. This, I think, it will be a little difficult for you to identify. This is a thermocouple on the left and thermistor on the right. And it is used for temperature measurement. Can anyone define what is how do you define temperature? So it is the measure of average kinetic energy of individual atoms and molecules that matter is made up of, or a substance is made up of. Okay. How do you measure? What are the units of measurement of temperature? This at least you should be able to answer.
Sir, Fahrenheit, centigrade, Kelvin. And,
so Kelvin, under what category of unit measurement it comes? It comes under SI measurement, SI units, System International, Kelvin, but commonly used is Celsius and Fahrenheit. So how much is 1 Kelvin? Again, that is another question that you will be asked. It's 1 by 20 to 273.15 of the thermodynamic temperature of triple point of water. The definition of Kelvin is 1 Kelvin is 1 bar 273.15 of thermodynamic temperature of the triple point of water. What do you mean by triple point of water? What is the triple point of water?
Exist in 3 states, all the 3 states.
It is the temperature at which ice, water and water vapor are all in equilibrium. Okay, that is the temperature that is called the triple point. What type of devices are used to measure temperature? Instruments you use.
Sir, mercury thermometers, then infrared thermometers.
Very good. Electrical, non-electrical, and infrared. So examples will be electrical resistance thermometers, thermistor or thermocouple, non-electrical alcohol and mercury, and infrared tympanic membrane thermometers, which we are nowadays regularly using for all COVID cases, because we don't want the same thermometer to go into everybody's mouth. So comparing thermistor and thermocouple, of course, thermistor is used in your PA catheter to measure the cardiac output. You use the temperature variation. You remember that? So all these things are the common thing that you have to remember. This is another ECG. What is seen in this ECG?
Sir, RSR pattern, sir.
RSR pattern. Right. That is in, you think it is in this one, V1, V2? No, I can just give you a clue. There is some abnormality in the first lead and third lead. Third lead, what do you see here?
Sir,
it's a S1, Q3, T3, evidence of pulmonary embolism. Yeah. So the usual causes are prolonged embolization, surgery, and malignancy. The risk factors are family of history embolism, malignancy, long bone fracture, sedentary life, obesity, and all these things. So what will be the clinical feature if a patient gets pulmonary embolism?
Sir, patient will have history of cough, chest pain, difficulty in breathing, and hemoptysis.
Can sudden death occur in pulmonary embolism?
Yes, sir. Sudden death can occur. Cardiac arrest.
Massive pulmonary embolism, you won't have any time to exhibit any symptoms. You will just like that drop dead. Okay. So it depends on the size and location of the clot. Large emboli blocking the major pulmonary vessels result in immediate death. But small size clots in smaller branches cause shortness of breath, anxiety, chest pain, hypoxia, hemoptysis, and arrhythmias. So how is PT diagnosed? How will you diagnose the pulmonary embolism? So you must know the history or risk factors, and if a patient who has a risk factor complains of these things, to be alive, it will be only a minor embolism. If they complain of shortness of breath, anxiety, chest pain, That is a minor embolism. So that can be diagnosed with CXR, EKG, where you will get this, what is called the S1, Q3, T3 features. Then you will have the MRI, CT, everything telling you. And D dimer level will go up. So how do you treat that embolism? Any clot, how will you treat? By thrombolysis, anticoagulation, or placement of filter and embolectomy. Okay. This is a very common thing which you all of you should be familiar with. What is shown in these pictures? I have purposely not selected a color picture. I have taken a black and white so that to see whether you people are.
Sir, it's internal jugular venous cannulation.
IJV cannulation. Oh. But why two pictures? It's a landmark based IJV cannulation, which is called both posterior and anterior approach. Okay. So what are the indications for IJV? All of you should be aware of that for monitoring CVP, for infusion of irritant drugs, insertion of pacing wire. It can be sometimes used for renal replacement, emergency venous access, and parenteral feeding. All these things are common questions. What are the contraindications? Patient who have coagulopathy, thrombocytopenia, skin infection, obscure anatomical landmarks, hemo or pneumothorax, all these things. Advantages and disadvantages, there are many, and complications, you can classify them to vascular, infectious, and miscellaneous. What is this? All of you should have seen this in your training.
Megill's
Megill's what?
type B.
No. It's
Yeah, you are right. Megill's Maples and F. It's not Megill. It is Maples and F circuit, also called as Jackson-Rees circuit. What are the indications for its use? Where do you use this?
pediatric cases.
Yes, in pediatric patients less than 20 kg weight for both spontaneous and controlled ventilation. What are the advantages and disadvantages of this circuit? Advantages, there is no resistance because there are no valves, minimal
space
bed
is
space, lightweight, and disadvantages are it will pollute the atmosphere more gases are spent, so not economical. Any idea what is this? This bag is called
It's
a
a expiratory hole, sir.
it's called a Kuhn bag, K-H-U-N, Kuhn bag. Okay. What is shown here? They all have one similarity, but a little bit. It's all T-piece in a different model, various forms of T-piece. Okay. And what is this? One of the museum specimens, not used nowadays, but
Type C, sir.
it is water
for
to and fro canister
to
with
and
a
fro
mask.
For infective cases.
This all of you must be aware of nowadays because we talk about this a lot.
Double lumen tube.
Double lumen tube, which end? Patient end or machine end?
Machine end.
Machine end connected to how two tubes are connected to two different things. What are they?
So the one side.
So machine end of the double lumen, one is connected to the breathing tube with a HME filter. Another is a non-ventilated lung for a CPAP with oxygen connection. Okay, so this is the connection. That. What are the indications for double lumen tube usage? This is another common question that will be asked in the exam. How do you classify the indications? Absolute and relative. Nowadays it is classified as lung separation indication and lung isolation indication. Okay. To prevent contamination of the normal lung. So absolute is now called isolation technique. The relative indication is now called lung separation method. Okay. So there are these things which all you can read up. So how to manage the hypoxemia that is likely to happen during one lung? You have to use FiO2 manual ventilation. Again, check the DLT position with the fibroscope. Check the hemodynamic status. CPAP application to the non-dependent or non-ventilated lung. non-operated lung, and PEEP to the dependent lung, and intermittent two-lung ventilation, and clamping the pulmonary artery at the earliest. These are all the answers that is expected out of you. What is being done here?
Cricothyroid function.
Cricothyroidectomy in a mannequin. Okay, needle cricothyroidectomy. So what is the indication? When will you do a cricothyroidectomy?
Some mostly cannot intubate, cannot.
Yes, very good. It's married out as a life-proceeding saving procedure in can't intubate, can't ventilate scenario. What is this person assembling here?
Jet ventilator. Sir.
Jet ventilator. But that is not regular jet ventilation. You can see what all. How is he? What is he using? See what are all the things? He is assembling something on his own. This is not a commercially available thing. So he has taken something here, connecting it
2
to
ml
something.
syringe.
He has taken a 3 ml syringe, which is connected a 7 mm adapter attached to oxygen delivery tube, connected to machine outlet and activated with oxygen flush. So you can see in between his fingers, there is a 14 gauge cannula. That orange color, you can see a small bit. So they have put a 14 gauge cannula, and that tip of the cannula is connected to this barrel of the syringe, and then oxygenation is being attempted. So the complications of this: technical failure, cannula can kink or obstruct, injury, surgical emphysema. All these things can happen. Name the instrument that is shown here.
Bowden's pressure gauge.
Bowden's pressure gauge. Every day you would have been seeing it in your theater. Is it Bowden's pressure gauge? If it is Bowden pressure gauge, you will have the name of the gas written.
So
there will be
Wright's spirometer.
Wright's respirometer. Okay, it's a Wright's respirometer designed by Dr. Basil Wright. Name of the parts: it has got inlet, outlet port, dial with the outer circle and the inner circle. So the outer circle is for measuring the vital capacity, inner circle for measuring the tidal volume. So two measurements that we can make with this are the inspiratory or expiratory tidal volume or vital capacity. So it can be used like this, by the patient blowing through that and then trying to register that. What is this patient undergoing? Some fluid is putting into the abdomen. Peritoneal dialysis. So in the patient is undergoing. So what are the indications of peritoneal dialysis? Or what are the indications for renal replacement therapy per se?
Yes.
Severe uremia, hyperkalemia, fluid overload, or severe metabolic acidosis. Okay. So in what mechanism the peritoneal dialysis works? It's both by osmosis and diffusion. The peritoneal membrane acts as a semi-permeable membrane and then helps. So there are two types of peritoneal dialysis. One is called the continuous ambulatory peritoneal dialysis. The second one is continuous cyclical peritoneal dialysis, otherwise known as automated peritoneal dialysis. Advantages: lesser side effects, continuous therapy, no needle, convenience of therapy at home and night, greater flexibility. Disadvantages: infection, daily therapy, need to storage space. You have to stock the dialysate fluid, hyperglycemia, weight gain, and all those things are there. Then the composition and volume of PD dialysate, it's a very rich in glucose. So patient may get hyperglycemia. And it is available in various sizes, 1.5 liters, 2.5, 3 liters, and contains this much percentage of dextrose, 1.5% dextrose, 2.5 or 4.5%. So patients who are even non-diabetic may have high blood sugar because of the use of such high sugar containing dialysate fluid. What are the different routes of administration of drug? Basic pharmacology question, which you have studied as a third year student. or for clinical
O-
student?
oral, intramuscular, intravenous,
Oral, IV, IM,
subcutaneous,
inhalant, sublingual, rectal,
sublingual.
epidural, intrathecal. Very good. Okay. What is bioavailability of a drug? What is the definition of bioavailability of a drug? It is a fraction of administered drug reaching the systemic circulation. So by whatever route, if you give it IV straight away, it is 100% bioavailable. Everything is available for the body. Whereas by other routes, whatever fraction is reaching the systemic circulation, it has to ultimately come to the blood to go to the desired organ, isn't it? So any drug which is given directly intravenously has got 100% bioavailability. But the other routes, they take their own time to reach the circulation and then go and get the effect. Okay, so that can be calculated by using this graph. So this graph, what does it depict? This will depict the bioavailability by calculating the area under the curve for both oral and IV doses. So bioavailability of a drug can be calculated using the formula area under the curve for oral dose divided by area under the curve by IV dose. What is first pass metabolism? As anesthesiologists, we should know a lot of basic pharmacology, physiology, anatomy, both to be a successful practitioner and also to pass your exams easily. So it is the metabolism of a drug before it reaches the systemic circulation. Okay. So ultimately, as I told, it should reach the blood. But before it gets into the blood, if it is getting metabolized, this is called the first pass metabolism. It can occur in bowel wall or in hepatocytes. How first pass metabolism can be avoided? Simple logic. Administration by sublingual, buccal, nasal, rectal or transdermal routes. If you give by these routes, it will escape from the metabolism done by the bowel wall or the hepatocytes. And by if you give IV straight, that is much more safer and much more 100% successful. So what route of administration is shown here? What drugs can be given by this route?
Transdermal.
This is transdermal. Very good. Transdermal route. So the drugs which we normally use are emla cream, fentanyl, nitrates, buprenorphine, estrogen. All these things are given by transdermal route. What are the advantages and disadvantages of this route? Easy to administer, ideal for those who don't tolerate oral, slow sustained release. These are all the advantages. Inconsistent absorption, delayed onset, need to keep changing the site. These are all the disadvantages. Patient undergoing GA has a change in the EKG like this, but he is clinically stable. What is happening here? You can see the pointing arrows are there. What are they? The ECG.
Ectopics.
Multiple ventricular ectopic seen since the patients is stable, observe him. But if they come in what is called run of 5, then you have to treat it by giving lignocord 1 to 1.5 milligram. If this condition deteriorates and ventricular tachycardia with a palpable pulse happens, what to do? Now suddenly this VPD turn into ventricular tachycardia. But the pulse is still palpable. What do you do? Assess the hemodynamic status. If patient gets unstable, get ready for defibrillation to correct the rhythm. Okay. But if the patient becomes unstable and then BP also crashes, what is the next step? That means tachycardia has become ventricular fibrillation, isn't it? When the pulse is not felt, it will become tachycardia becomes fibrillator. So what is the treatment of ventricular fibrillation?
Defibrillation.
Defibrillation. Before that?
CPR, sir.
CPR. Start CPR, then defibrillate with 120 to 200 joule shock. Antiarrhythmic agents like amiodarone, magnesium sulfate. Find out what is the cause and what to do if there is evidence of acute myocardial infarction.
Sir, we have to support the circulation
Urgent
by
PCI by needed if the condition does not improve.
Yeah.
Okay. So what is shown in this picture? Patient is undergoing some testing, cardiopulmonary exercise testing. Okay.
Yes.
What is the purpose of this test? It's a non-invasive test for testing the function of heart, lungs, and musculoskeletal system. What factors determine the exercise tolerance? Pulmonary gas exchange, cardiovascular function, and skeletal muscle metabolism. How is fixed equation important in cardiopulmonary exercise testing? So fixed equation we normally use for finding out the cardiac output, isn't it? Fixed principle. But fixed equation is also used here. At rest, oxygen uptake is the product of cardiac output times the arteriovenous oxygen difference. So the VO2, that is oxygen uptake or consumption, is equal to stroke volume and heart rate, which is cardiac output, multiplied by the arterial oxygen minus venous oxygen difference. That is what you have to multiply. So it is expressed as oxygen uptake is expressed as oxygen per kilogram per minute, which is 1 in 1 minute. 1 minute is equal to 3.5 ml per kg per minute of 70 kg person. What two important parameters are obtained by doing cardiopulmonary exercise testing?
VO2 max.
VO2 max and ventilatory anaerobic threshold, oxygen anaerobic threshold. Okay, both are. Now, a 62-year-old male with 15-year duration admitted with complaints of vomiting, fever, rigor, patient drowsy, tachypneic, tachycardic, febrile. ABG is taken at room temperature, room air with temperature 38. These are the findings. pH is 7.28, PCO2 24, bicarb 14, PO2 82, PE 11, sodium 138, chloride 92, potassium 5.9, glucose 390, ketones 3.4. What is your interpretation of this ABG? Very good. Excellent.
Yes.
Partially compensated metabolic acidosis with high anion gap, hyperglycemic, ketonemia, hypoxemia consistent with DKA. So exam, you have to describe all these things like that. Even though you have come to the diagnosis straight away as diabetic ketoacidosis, in the exam you have to express your answer like this. If you are given a paper and asked to write like what they did in the last 2 years Osce exams, you have to write everything. How do you treat this? DKA treatment is a very common question. ABC survey, oxygen supplementation, hydration with normal saline, plain insulin to reduce hyperglycemia, check potassium from second hour and treat if that is going below 3.5. So what is shown here? Any idea? It's a carbon dioxide dissociation curve. Normally you get the oxygen dissociation curve in the exam, but carbon dioxide dissociation curve also can be, it is a linear curve. Unlike the sigmoid shaped curve of your oxygen dissociation, this is a linear curve. So what do points A and B mean in the graph? They say it is a CO2 there, indicate the volume of CO2 in arterial blood, and it can be at 40 millimeters of CO2, the total volume is 480 ml, at 46 is 520. How is CO2 transported in blood? What are the methods of transportation of CO2? This basic physiology question. So it is then the 3 ways. One is in dissolved form, second is bound to hemoglobin as carb amino hemoglobin, and 3 as a bicarbonate. What is Hamburger phenomena, otherwise called as chloride shift, is the mechanism by which the carbon dioxide is taken from the tissues to the RBC. And what is Bohr versus Haldane effect is, it's a difference of the blood PCO2 taking from the tissue and Haldane at the lung level. So transportation of CO2 from tissue to lung, the two things are called. Hagen-Poiseuille equation is a equation very commonly used in your anesthesia for various things. Okay? So defines the flow through a tube take into consideration the length, radius, and viscosity of the fluid, and it is applicable only to the Newtonian fluid with a laminar flow, not for turbulent flow. The formula is Q is equal to pi PR4 8NL. So Q is the flow in liters per second, P is the pressure in pascals, R is the radius, L is the length, N is viscosity. Even though we write it as like N, it is called eta. It's a Greek numeral, and the Pascal is in SI unit. A flow of fluid through a tube increases with increase in pressure and increase in radius of the tube. So flow reduces if the viscosity and length of the tube are more. So what are the applications in anesthesia for this?
Merclon IV lights.
IV cannula size, then mainly endotracheal tube. Larger the radius of the endotracheal tube, lesser the resistance to breathe, especially in children. And larger the radius and shorter the length of IV cannula, increase will be the flow. Okay. Can you identify the black oval part attached to the ET tube?
Anaconda device.
Anaconda device, very good. It's an anaconda anesthesia device. Where do you use it?
ICU sedation, sir.
ICU sedation, very good. Modified form of HME filter. It is used mainly for sedation in patients on ventilator in ICU. How does it work? Of course, there is a device contains a miniature porous evaporator rod and converts the volatile into vapor. The liquid anesthetic agents pumped into the evaporator. So the same thing is recaptured and reused. So that is the advantage. Both isoflurane and sevoflurane can be used. And what is this person doing?
Valsalva maneuver.
Very good. He is performing a Valsalva maneuver. How should you do a Valsalva maneuver? Forced expiration against closed lattice after full inspiration to create a pressure of 40 millimeters of mercury, and it should be held for 10 seconds. That is the full correct method of doing Valsalva. And who used this for and for what purpose? Why it is called Valsalva maneuver? It first used by Antonio Valsalva, an Italian anatomist, to expel pus from the middle ear. So by doing this, he forced the eustachian tube pressure, and whatever middle ear pus was there, it was able to come out. So he was using it for that. And now what do we use it for?
For autonomic nervous system.
Fantastic. It is used to test autonomic nervous system function. What are the changes in BP and heart rate that will happen in a normal person? There are 4 phases. All of that you can read it up. What is the abnormal response? You will have square wave form seen in congestive heart failure and constrictive pattern instead of this normal wave. And BP change will not be, in autonomic neuropathy, no increase in BP will happen and no change in pulse rate and no overshoot will happen. So that is how you can find out. And patients on ventilator or hypovolemia will have an exaggerated drop in BP instead of increase in BP. What is shown here?
Muscle
junction.
Very simple diagram of neuromuscular junction. Can you describe the parts of a neuromuscular junction? So it can be nerve terminal, synaptic cleft, and motor end plate. So presynaptic or nerve terminal, there's a gap which is called the cleft. Then there's a motor end plate or the postsynaptic motor end plate. What is the size of the synaptic cleft? That is the gap between the presynaptic nerve terminal and the postsynaptic motor end plate. What is the size of this gap? It is about 20 nanometers. Okay, synaptic cleft is approximately. Earlier they used to call it as an angstrom units, 15 angstrom. Now it is converted to nanometers. So how many acetylcholine receptors are present at the motor end plate? These are all the acetylcholine receptors, these green things that you are seeing. How many are there numbers? Any guess?
In millions.
They are in millions, of course. They between 1 to 10 million receptors are there. What are the types of acetylcholine receptors? They are nicotinic and muscarinic.
Muscarinic.
Of course, subgroups of muscarinic also is there. That can call muscarinic 1, 2, 3, 4, 5, like that. Subgroups are, some isoforms are there. And what types of nicotinic receptors? There are 3 types: pre-junctional, post-junctional, and extra-junctional nicotinic receptors. Okay, so you can see there are pre-junctional receptors also here. These are all pre-junctional acetylcholine receptors. They are responsible for stimulating and opening the calcium channel so that calcium can enter, and then only the acetylcholine stored in the vesicles can be released. Okay, so which disease that calcium channel will not work properly? The presynaptic calcium channels, when in which disease they are affected?
Myasthenia gravis.
Oh, Myasthenia gravis, it is the post-terminal, post-synaptic acetylcholine receptor.
Lambert-Eaton syndrome.
Eaton-Lambert syndrome. Very good. So nicotinic and muscarinic receptors, ionic receptor. The difference is they are ion receptor, the 5 pentameric protein ion channel receptor, whereas these are called muscarinic GPCR. What is the expansion of GPCR?
G protein coupled
G
receptor.
protein coupled receptors. Very good. So they are broken by acetylcholinesterase. So in myasthenia, autoimmune disease, the AB, that is the antibodies are produced against the acetylcholine receptors, blocking the action, resulting in muscle weakness. That is the postsynaptic. Whereas in Eaton-Lambert, it's a presynaptic disorder, preventing the release by affecting the calcium entry. So what is shown here?
Cardiac action potential.
Cardiomyocyte action potential. Is there any other action potential in the heart which is different from this?
Pacemaker potential, sir.
Pacemaker potential. Okay, there is a difference between pacemaker potential and the myocyte potential. Pacemaker, what is the pacemaker?
SA node, sir.
SA node is the main SA node is the main pacemaker of the heart.
SO node is the name, synovial node. But what is a pacemaker? It is a specialized tissue of myocyte. Okay,
Yeah.
it is slightly different from the regular myocyte. Okay,
Yes.
so these are the things, right? So what is this formula? You have a plasmolite, sodium bicarbonate, mannitol, magnesium, lidocaine, potassium chloride. All these things are added in a particular ratio. And this is called Del-Nido formula. Where do you use it?
Cardiopulmonary bypass.
Cardioplegia. Yes,
Cardioplegia.
used as a cardioplegia solution. Okay, right. So thank you very much. I close this now. So I think I don't have time for taking any questions or any doubts today. I'm very sorry about it. I'm in a rush. So from next class onwards, I will, as I did today, I will send the material to Dr. Kamachi, and I can send you, he has already sent you some hint as to what will be the questioning like and what topics are going to be discussed. So, but it was given very late, so I hope that you all did not have time to prepare. So I will ask him to send the hint much earlier so that you can all go through that and try to prepare. Okay, and don't get disheartened by any that you cannot answer these questions. By training and practice, you definitely will be able to answer and do it in a much faster time. That's what I want you to achieve. You must be able to answer quickly so that within the given time in the exam you will be able to complete it. Okay? Shall I close, Kamachi?
Thank you, sir.
Okay. Thank you very much. Right.
Thank you very much, sir.
Thank you.
Thank you, Vasanthi. Are you there?
Thank you. Yes, sir. Very much, sir. Thank you, sir.
Thank you,
Thank
Ma.
you.
Thank you. Thank you.
Thank you, madam. Thank you, sir. And thank you, dear students. We'll see you once again next week for a very interesting session. Thank you. I'll sign up this meeting. Thank you, sir.